Hello, everyone. Welcome back to our NCLEX review. And for the newcomers, we are currently on the 14th day of our 90-day free NCLEX review series. And we are making a special announcement to make. We are changing the schedule of the daily live classes at 9 p.m. Eastern Standard Time, starting on June 5th. Again, please take note of the schedule change. We are going to conduct the daily live stream at 9 p.m. Eastern Standard Time starting on June 5th. So please take a look into the first page of our PowerPoint. That will be the new schedule. So we are covering all the nursing subjects, providing explanations for 2000 NCLEX questions. And please don't forget to spread the word to your friends preparing for the NCLEX and tell them to subscribe and also enable notifications for the updates. And make sure that you are going to check also onto the description box below because we have a lot of information there for you to check out. And I just want to make sure that you give us your feedback. So feel free to share your thoughts or questions in the comments section or clarifications on any discussed topics. Now, we're also offering the NCLEX course at stancoast.nclexcoaching.com. And please check on our website. And we want for you to get right into the heart of each topic with clear and straightforward lectures. Now, I really want to challenge yourself with a huge bank of over 3,000 NCLEX questions and an additional 5,000 nursing brainstorming questions. And if you need a quick recap, our audiobook and also the bullet book are perfect for quick review. You can do that. And also arm yourself with 100 hours of dedicated NCLEX preparation and make sure that you dig deeper into the material with our extensive library of on-demand videos. And of course, you really need to test your knowledge with the mock exams and comprehensive test series that we have. And this is something that you can avail for the entire 6 months of your subscription. And you can do this anytime, anywhere, 24/7. And please don't forget that we also offer about 200 NG and test questions in order to enhance your preparation. Now, I really want you to consider this to make this as your ultimate comprehensive NCLEX preparation. Now, for today, I will be talking about the concept on the pulmonary embolism or the med-surg content. Now, this time I really want you to imagine yourself as the registered nurse. Picture yourself as the registered nurse this time, working in the medical surgical unit, and you're taking care of this particular patient. You probably are just doing this for the first day on the week of your shift, right? So this is probably the first time that you met this patient who just had a total knee replacement about 2 days ago. And you're routinely assessing your patient, and all of a sudden, he is complaining of chest pain and a change in their vital signs. What would you do at this point? Would you be able to manage this really and immediately? So I really want you to keep yourself in that situation. And as we go through the discussion about pulmonary embolism, I really want you to put yourself in that situation and assess if you're quite ready to answer the test question, especially in the NCLEX. Now, going back into the description of the pulmonary embolism, this is a serious condition wherein a blood clot can travel from places like the pelvic veins or the deep veins of the lower extremities, and they're going to travel up into the lungs. And it's definitely it's not a good situation. All right. So this is an emergent situation that would really require immediate attention. Now, before we go further, we need to classify first what PE is all about. And so this is probably not quite presented well in the nursing textbooks, but based on the medicine books that I have looked into, we really need to go deeper because we need to match the kind of nursing care with the manifestations the patients is having or are having, okay? And so we're going to have to talk about the different types of the PE, starting with the massive embolism. Now, this is that type wherein there is instability in their hemodynamic status. Okay, and this is the most serious type of PE because it causes big problems with blood flow and it can lead to a sharp drop in the blood pressure. Imagine that. Okay, so you're seeing this right now that there is going to be a significant drop in their blood pressure when they have a massive PE. And this is going to be maybe a drop of the systolic blood pressure less than 90 mmHg, or let's say 40 mmHg for that diastolic. Now, this is like a major traffic jam inside the lungs, and this can really cause so many things to occur. Um, so, with this kind of massive embolism, it could be caused by a larger clot, maybe going into a major section of the pulmonary artery. Okay, so again, think about a bigger clot that has lodged into a good chunk of the pulmonary artery. So this will really cause a huge traffic inside that lobe, probably, and could probably affect a quarter of that left lung or the right lung. And so this is something that's going to really occur here. There will be some elevation of the troponins, especially because when there is a big clot blocking the blood flow in the lungs, then there is that large obstructing object that can put a lot of pressure on the right side of the heart. Okay, so I really want you to go back into the anatomy and physiology that when the blood clot lodges into the pulmonary artery, so what do you think can happen? This can cause detour of those blood in the pulmonary artery circulation. It can somehow back up into the right side of the heart, the right ventricle, right? And so this can really strain and cause issue to the heart muscle. And we are talking about the right side of the heart here. And so this is going to cause a release of protein called the troponin, okay? And so looking into the laboratory, our reference value for a normal troponin level, somewhere around 0.01 nanograms per ml. So anything above that would be would help you in determining that there is such an involvement with the myocardium. Okay. Now, another thing that will be seen in the lab test, which I forgot to put in the column here, is that there will be an elevation of the BNP, the beta natriuretic peptide, and this is indicating that there is stress on the heart due to the pulmonary embolism. Now, please take note that the BNP is something that is released when there is dilation, there is enlargement of a chamber. For example, the right ventricle that is enlarged because of the backflow of the blood coming from the pulmonary circulation into the right side of the heart. That enlargement alone can cause the release of that peptide. It simply means that it's wanting to cause this increasing volume of blood to be excreted via the kidneys. So it's only triggering by releasing that amount of the BNP, but somehow it's not going to work. All right. Now, another problem that you can probably that you can see in the diagnostic test is the dilation of the right ventricle, or it could be the start of the right-sided heart failure. Okay, please take note of that. There will be right ventricular impairment. And so right-sided heart failure can occur in a matter of hours just because of this massive clot lodging into this significant portion of the pulmonary artery. Now, with that, if this is not going to be treated instantaneously, well, the patient can go into, oh, there you go, cardiogenic shock. And so some of these patients can die instantaneously right after they experience that massive embolism. All right. And we had scenarios about this real time in the workplace of work in the past. They are not going to be able to revive this patient if it has been quite delayed. I mean, the treatment has been delayed for this particular patient. So I really want you to think about this kind of massive pulmonary embolism. So when you're going to encounter this in the NCLEX, make sure that you review the scenario, look into the diagnostic test. Are these present in this particular patient? Or maybe this is in a milder form of a PE, or it could be a submassive type. So again, let's recap the massive type of PE. This will involve the malfunction of the right side of the heart, also the ventricle. There will be dilation of that chamber. There's going to be a release of the troponin. So this is going to be elevated. And also the BNP will be elevated. And the blood pressure here will be in the low side, especially for the systolic and the diastolic. Look into the numbers. Less than 90 for the SBP, less than 40 for the DBP. All right. Now, I hope that you were able to understand that. Let's move forward to the submassive. So I would probably consider this as a moderate risk type of PE. And this is going to, the description of this type is that the patient is somewhat kind of like in a normotensive side as we are talking about the blood pressure. And the type isn't that as extreme compared to the massive type. It's still serious though. And the patient won't be in a form of a shock or let's say low blood pressure, but they'll likely to have some trouble with the breathing. Could be some tachycardia or their respiratory rate will also increase. Now, the patient here might also experience some right ventricular dysfunction, but not as bad compared to the massive type of PE. Now, we're going to talk about, oh yeah, there's also elevation of the troponins, but I guess this is not as severe as compared to the massive type. And there will be some right ventricular dilation as well, but this would not really compare to the massive type. And then we do have the last one, the low risk type of PE, which is the patient will manifest only a few symptoms or maybe asymptomatic. They probably would not complain of any difficulty of breathing, not even a tinge of pain. And so you really have to keep assessing this patient because we don't know if this clot, being a small one that is lodging maybe into a pulmonary capillary, and if we are not treating this patient, this can cause the clot to grow, as we know that there is circulation in the lungs, right? And so if there is no treatment, especially anticoagulation, this clot can grow bigger. So you don't have to be relaxed at all when you're dealing with a mild type of PE because something's gonna happen really quickly. Now, there's also no signs of hypotension because it's not really causing that backflow of the blood coming from the pulmonary circulation into the right side of the heart. There is no effect in the cardiac output in this mild form. Okay, so if you're thinking about a low blood pressure in the patient in the massive and also, the massive type, think about the cardiac output is being affected, and this is because of the decline in the function of the right ventricle. All right. Now, there's no dilation of the right ventricle in the low risk type of PE. And again, we are going to monitor this patient, make sure that we are treating this patient accordingly as we receive new labs because the patient will be checked on their troponins as well. So we want to make sure that we are attending to this patient carefully. Now, we're going to tackle about the etiology of the PE. And so I don't know if you still recall the Virchow's triad. This is a section of the PE that you really need to go back to because this is really going to help you understand how the blood clot forms. Okay, so the Virchow's triad is going to encompass about the different aspects here. And we're going to talk about the first letter here, which is the H, hypercoagulability. So what is this? Well, basically, this is something that can occur maybe because of so many factors. It could be caused by the pregnancy, or maybe with the use of the contraceptive medications, or it could be cancer, or chemotherapeutic agents, or maybe some inherited thrombophilias. There is some problem with the clotting mechanism in this person. And so the thrombophilias can include those diseases such as the protein C deficiency, or maybe the protein S deficiency, or the antithrombin deficiency. So, all right, let me Repeat those. So the thrombophilias include the protein C deficiency, the protein S deficiency, and antithrombin deficiency, and could be the hyperhomocystinemia, or it could be homocystinuria, or the antiphospholipid syndrome. So there's a whole lot of thrombophilias that can be involved under the hypercoagulability factor. Now let's talk about the endothelial damage. Well, guys, this is something that can occur as an insult from cigarette smoking chronically, or it could be chronic elevation of the blood pressure, or maybe the person has a long-standing history of atherosclerotic disease, and this is result to the hyperlipidemia. And so when this happens, when there is an insult to the wall because of the high pressure, there is what we call as the turbulence that can happen inside the blood vessels. And when this turbulent flow within the vessel occur, the rate of the blood flow becomes too rapid, and maybe the blood flow passes over an affected surface, and this can cause disoriented or disordered blood flow and will cause some friction of flow within the vessel. And so with that, this can lead to the formation of the blood clot in that particular blood vessel. So these are your smoking, could be the chronic hypertension, or could be the atherosclerotic disease caused by hyperlipidemia. And let's tackle about the S, which is going to include the stasis, the venous stasis factors. And this can be composed of the following. It could be caused by atrial fibrillation, wherein there is irregular heart rhythm. And of course, with that, it can affect the cardiac output, meaning the pumping mechanism especially is going to cause the formation of the blood clots in the heart, especially the left side of the heart. When there is now sluggish circulation because of the AFib, this can form the clots, and eventually, when the ventricle is able to pump that sluggish blood with the clots in it, it can push that clot into the circulation, especially could go to the brain, right? And it can cause stroke. Or possibly it can go into the other circulation as well. All right. Now, we're also going to talk about the, well, if it's going to go back into the, if it's going to cause into the backflowing of the blood into the pulmonary circulation, there you go. That blood clot can also lodge in the pulmonary circulation, and this will end up with a pulmonary embolism. Now, we also have valvular heart disease. That's another major risk factor in the development of PE. And for the patient that we created as a sample for the scenario, prolonged immobility, it could be surgery, or it could be trauma, or maybe a patient that is postpartum, or a patient that has a decrease in their physical activity. So these are the things combined can lead to PE. It doesn't really mean that you have to have all the factors here, but at least you have some of these contributing factors for the PE. All right, so I hope that you're able to identify these, and don't forget the HES, hypercoagulability, endothelial damage, and stasis. We're talking about venous stasis. All right, don't forget about the HES. Now, we're going to talk about the mechanism behind the pulmonary embolism, and this is going to involve several stages. So we're going to see here, this picture over here. Let me magnify this one. So here we go. The blood clot coming from the lower part of the body, especially maybe the deep veins or the pelvic area. A patient that probably had been pregnant, with a gravid uterus, it really is going to cause some sluggish circulation from the pelvic area, or maybe a patient that may have a clot from the leg, a DVT, deep vein thrombosis. And when this happens, let's say there is now mobilization or dislodgement of that clot from that blood vessel. it will go into the venous system and it will go back to the heart. Remember, it will follow the circulation. It goes back to the heart via the vena cava. Of course, this is quite huge of a clot here. This is scary. And so it can possibly go through the chambers of the heart, the right side of the heart, atrium, the right ventricle, can go into the pulmonary artery, or it could be going into the right side or the left side of the pulmonary artery. Boom. As soon as it goes into a smaller size artery, maybe an arterial, then it's going to get stuck there. All right. Now let's go into the next picture here. Supposing this is now the clot. Well, this is quite a smaller one compared to the one that we had in the prior picture. So this is probably going to be considered, or let's just pretend this is a huge clot, right? And so with that clot lodging into this section of the capillary or the artery, pulmonary arteriole maybe. So this is now going to compromise the blood flow. So you'll see here that there is now a detour of the blood because it's not allowed to get into this section of the capillary. So it will cause the detour of the blood into the other networks. Okay. And so this is now going to cause the change in the exchange of gases here. What do you think about the exchange here? Still, the person can breathe, right? We haven't had any complaints yet. And so while the clot is being lodged there, when the patient breathes, yes, they can still inhale. The O2 comes in, it will inflate the alveolus or the alveoli. However, there is no exchange of gases in this section. Nada. All right? And so it will just keep inflating, deflate, but there is no exchange. However, though, with that detoured blood, take a look at that one. There is diversion. And so the presence of that clot can now disrupt really the blood flow. And this will now cause diversion, and it can engorge the remainder of the blood vessels that where the what do you call this? The detoured blood vessels. And so this is now going to cause some issues. This will engorge this particular part of the blood vessels. I said engorge, it's congested, it's going to affect the permeability of that blood vessel. And so with that, it will now cause shifting of the fluids from the capillary into the alveolus. That's why there will be presence of crackles in some forms of PE, right? So with that accumulation, and of course there's still exchange maybe of gases, but there is now poor ventilation to perfusion ratio, okay? Now, along with that, with the presence of the clot, it can also lead to pneumonia and acute respiratory distress syndrome. And yes, there's just a whole lot of things that can cascade out of this one. Now, looking into that picture really, with that increased perfusion in the adjacent capillaries, this can cause a ventilation perfusion mismatch as the capillaries receiving the ventilation, but they have excessive blood flow. And this will now cause inefficient gas exchange. Now, the key consequence of the pulmonary embolism is the disruption of the VQ, or the ventilation to perfusion ratio, in the affected lung regions. And so, when we are talking about that, in areas where the blood flow is maintained, but ventilation is compromised due to the diversion, or let's say the formation of that dead space right here. This is pretty much like a dead space, okay? Now, along with that, there is also a combined effect with the pneumonia wherein they're going to cause that acute respiratory distress syndrome, and also the consolidation of the lung tissue, which can also further the impairment of the gas exchange. Now, with that, this will also cause the development of secondary thrombotic events, or it can really worsen the situation here if the patient's not dealt with accordingly in a timely manner. Now let's go back here. Now we are not done yet with the mechanism. Now we will talk about how the right-sided heart failure can happen after a massive type of PE? Well, I already said something about that earlier, right? But I just want to make sure that you are getting this one. So remember about that detour right here, and a portion of that blood can go back up into the pulmonary artery and back into the right side of the heart. And take a look here. Pay attention to the size of the right ventricle compared to the left ventricle. With that massive embolus stuck into that artery, this can really cause a rapid development of the right-sided heart failure. And again, this can lead to a decrease in cardiac output and also a decrease in the blood pressure. That's why the person will end up with significant hypotension, less than 90 mmHg for the systolic and less than 40 mmHg for the diastolic. So I hope that you were able to catch this one. Now, look into the backflow mechanism here with the blood backing into the left side of the heart. This can also backflow into the venous circulation. So chances are the patient can manifest that positive JVD, jugular venous distension, in severe cases of PE. All right, so don't forget this because this can potentially going to come out in your exam. Now, I hope that you're able to get a better grasp about its mechanism in the severe form. Now, we're going to go into the assessment findings of the PE. And again, we are going to expect that not everyone will have the same manifestations. Again, the patients here will have a variety of manifestations, as it's going to depend on the severity or the size of the blood clot. Okay, and so for some patients, they are going to complain about sudden difficulty in breathing and also chest discomfort. And of course, this is caused by the obstructing clot in the pulmonary artery, which can reduce the blood flow to the lung tissue and can lead into the hypoxia, right? There is going to be low oxygen levels that can result into the shortness of breathing. The patient will be dyspneic, and the reduced blood flow and also the increased pressure in the pulmonary arteries can also cause the chest pain. And they're going to describe this as a pleuritic, sharp type of pain. And their heart rate will be faster, their breathing will be faster in order to compensate for the reduced oxygenation of the blood. And the body will also respond with these tachypnea and also the tachycardia in order to hopefully increase the oxygen delivery to the tissues and to maintain the cardiac output. But again, this compensatory mechanism will fail if the treatment is going to be delayed. Now, we're also going to see our patient coughing, and could be, they could have some crackling sounds in the lungs, which is actually an adventitious sound. And like I have said earlier, there is now shifting of the fluid from the capillary into the alveoli because of that increasing permeability, which allows the shifting of the fluids into the alveoli. And there is now consolidation. That's why when you're going to auscultate, you're going to hear those crackles and rails. And again, these are abnormal sounds. You're not going to sit on this one, guys, because crackles are just a few things that you should be mindful about. So basically, this is the abnormal fluid accumulation and eventually in some other portion of the lungs. Remember about the dead space? If there is a huge chunk of clot that has lodged in a major artery, this dead space could be probably a quarter or half of the right side of the lung. And this can lead to atelectasis, the collapse of the lung tissue because of the impaired blood flow. Now, remember about atelectasis, that this is, it's going to progress into something else. It could possibly lead into shifting, the shift of the trachea. We don't want to get there. But yeah, you got to keep assessing your patient. Now, there's also coughing up of blood, which is the hemoptysis. And this is caused by several mechanisms. So if you did not really get why they're going to end up with hemoptysis, well, when the artery gets blocked, the lung tissue can become ischemic. Simply means that it's not receiving enough blood, right? And eventually it will lead into the infarction, dying of the lung tissue. And with that, this can lead to the bleeding into the airways. Now, maybe if it's uh, something else, it could probably be that the pee itself is allowing that increasing pressure in the capillaries, right? Wherein the small blood vessels of the lungs can cause these vessels to possibly rupture and lead into the bleeding. And it might be expectorated as well. Now, if there is an inflammation, which is actually triggered by the pee itself, the inflammation can increase the permeability of the blood vessels. And this is now going to allow the red blood cells from the capillaries, and they're going to leak into the alveoli. And eventually, when this being cuffed up, you're going to see the hemoptysis. So it could be that red sputum or pink or the streaks of blood in the sputum when they're going to cough up. So that could be present in this patient with a massive embolism. Now, there's also that sense of impending danger or dread, and this is the result of the hypoxia, of course, and the body's stress response and the stimulation of the sympathetic nervous system. And this can trigger the anxiety and also feeling of doom. Now, there is also pleurisy here, which is pretty much the inflammation of the pleura, which is the lining of the lungs that will occur due to the reduction of the blood flow and also the presence of the embolus. And this can really cause that sharp chest pain that can worsen with breathing. Please take note of that pleuritic type of chest pain. Now, there are also going to be pleural friction rub when you're auscultating the patient. You will hear that grating sound that you can actually hear through that stethoscope. And again, this is caused by the inflammation of the pleural surfaces that rub against each other during the inspiration. Now, the patient here, especially for those who is in the middle of the right-sided heart failure, this is an ongoing heart failure here. And so you probably will hear the heart murmurs, S3 and S4. So these are your extra heart sounds that can happen due to the increasing pressure in the right side of the heart as they're going to work hard to pump the blood into the obstructed pulmonary arteries. That is why there will be that swooshing sound that will create the S3 and also the S4 sound. Now, the patient will also experience some diaphoresis, which is basically sweating, which is much more of like beads of sweat kind of thing. And this is a common stress response due to the activation of the sympathetic nervous system in response to the pain that the patient is experiencing and also the hypoxia and anxiety. Now, there's also going to be low-grade fever, and this is caused by the body's inflammatory response in regards to the embolus and possible infarction of the lung tissue, which can cause a mild fever as well. Now, there's also hypoxemia, low oxygen saturation. So you will never gonna miss this, especially if you're gonna end up with a patient with a massive embolism, God forbid. But yeah, you probably will encounter this. And so the blockage probably is somewhat kind of huge, and this is really gonna cause some significant impairment of the gas exchange and a reduction in the oxygen levels in the blood. So you're probably going to see the cyanosis as well because of the low oxygen saturation, and this is caused by the severe hypoxia. And yeah, you will see your patient kind of like ashen looking, bluish discoloration around their mouth or the lips. And probably you're going to see some muddling into the lower extremities. No, don't like that at all. Now, there's also going to be petechiae, and these are pinpoint bleeders. And you can find this over the chest area of the patient or in the axillary, could be the right or the left. And these red or purplish spots can occur because of possible capillary rupture from the increased pressure into the pulmonary circulation, or could be as a result to an impending, or it could be a disseminated intravascular coagulation, DIC, which is a common complication of massive or severe form of pulmonary embolism. Now, guys, take note that when there is PE, the blood supply to the brain is going to be impaired, and not just the brain, the liver, the kidneys, and the other major organs, spleen, pancreas, everything will be affected. But I'm just going to show you the most organs that you can exactly see during the quick assessment. And so the brain will be deprived of oxygenated blood, and that's why the patient will end up with a syncope. They will have that sudden drop in the blood pressure and will lead to a blood supply compromise to the brain. And yes, the patient will end up with near syncope or probably syncope. So this is something that you need to be mindful about. So there you go. These are just generic manifestations and could include both the moderate or the submassive or the massive type of PE, or maybe a little bit of the milder form or low risk type of PE. So again, you really need to do your diligent assessment here. Look into the labs, the imaging studies to see how bad the PE is. And again, our treatment is going to be instantaneous at this point because the clot can grow if we are not gonna treat it with the anticoagulation. All right. So let's go further here in our discussion. We're going to talk about the different diagnostic tests. And some of these tests have been discussed already the other day. And so I will be talking more about the tests that I was not able to include the other day. And so I'll just mention some of those tests that we have already tackled. All right. So one of those testing here is the computed tomography scan, or simply known as the much more sophisticated one, which is the multi-detector row computed tomography angiography, or known as the MDCTA, which is going to be the preferred method for the diagnosis of the PE when it is accessible, because it will really offer a much excellent visualization of the lung tissue. Now, another testing here is the VQ scan, or known as the ventilation perfusion scan. So what is this? Well, this is a kind of testing, just right in this picture right here. Let me magnify that. So this is a two-step procedure or two-part test that will scan the flow of the air and also the blood within the lungs, and this can also identify a PE, right? So what is this VQ scan, if you're not quite familiar? This is going to measure the airflow, which is the ventilation, and the scan will measure how well the air flows through the lungs. And then it will also measure the blood flow, the perfusion, wherein the scan will look into the blood flow into the lung fields. Okay. So what's going to happen here? If you're going to be the nurse preparing for this patient for the VQ scan, no matter what department you are, maybe you're working in the ED, or it could be in the med-surg unit or the critical care, you really need to inform your patient what's going to happen to them or what is expected. What steps are they going to be able to anticipate for this kind of testing? All right. Now, again, this will require the placement of the patient on a special table while the scanner will take pictures of the lungs. And during the ventilation phase, the patient will be inhaling. They will be given a radioactive gas, or let's say an aerosol. That is the technetium labeled aerosol or the xenon gas. And so the patient will breathe into the tracer through a mouthpiece or a mask. So showing you again the picture here. Look at that. So they actually have that mouthpiece in order for them to inhale the radioactive agent or gas or the aerosol. And this will really help in assessing the airflow of the lungs. Now for the perfusion phase here, the patient will be given an injection of a radioactive tracer into the vein. And usually this is going to be given into a regular peripheral IV access. And so what is expected here is that the tracer will travel through the bloodstream and this will lodge into the capillaries of the lungs. Okay, so this will really allow the imaging to capture those areas wherein there is low perfusion or low ventilation. Now, again, with the use of the gamma camera, this is going to take the images in order to see the distribution of the tracers, the radioactive gas, into the lung fields. And so this will really identify any of the discrepancies between the ventilation and also the perfusion that could indicate the E. Now, to which type of people the VQ scan will be offered? Well, this is a procedure that is going to be ordered for those patients who cannot undergo the CT scan pulmonary angiography, which actually going to involve the contrast agent. Maybe they're allergic to that, or maybe they had an adverse reaction to that kind of agent in the past. And so this is not going to be, the VQ scan will be the recommended testing for them. And so this is also going to be much more suitable for those pregnant women, or maybe for those patients with the renal failure because of the compromise in their excretion of the waste products. And so they are gonna be qualified to have the VQ scan instead. All right. And also for those with allergies to the iodinated contrast material in the pulmonary angiography. And so this would be the better option for them. Okay. Now let's talk about another testing here. So I really hope though that you're able to understand about the significance of the VQ scan. Again, this is going to detect the discrepancies in the airflow and the perfusion of the blood into the pulmonary lung fields. Okay. All right, now let's talk about the pulmonary angiography. This is going to be the definitive test for the diagnosis of PE when, let's say, the MDCTA is not available. Although this kind of test is somewhat kind of expensive and also invasive, but again, be reminded about this type of procedure that it is going to involve the insertion of a catheter into the vena cava in order to view the embolus. And so with that insertion, there's going to be some risk involved. And yeah, much more of a risk compared to the VQ scan. And this is a test that will require the patient to sign consent and make sure, of course, the patient receive the thorough explanation from the medical provider before they're going to allow them to have this testing done. And so part of the care here as nurses, we're going to have to assess and monitor for their vital signs, their oxygen saturation, and also assess for the anxiety. Monitor them. Maybe if you're the nurse in the interventional radiology, that would be awesome, right? When you're going to be able to see this kind of testing. And so this is your responsibility here, that you're going to continuously monitor your patient with this type of procedure. And you got to watch for the bleeding. It's because it's going to involve the insertion of the catheter. And so watch for the bleeding that probably will come out from the insertion site. Or it could be some edema, or maybe some swelling into the particular insertion site that may cause detour, or maybe impairment in the circulation of the blood. So you have to pay attention to the expected complications as well. Now let's talk about the chest x-ray. All right, so chest x-ray really is not the main diagnostic tool for the PE, but it can also give us some information that may support the occurrence of pulmonary embolism. Maybe there is an elevation of the diaphragm on the affected side, or could be pleural effusion. Again, I'm talking about the elevation of the diaphragm or on the affected side, or could be a pleural effusion. But with a chest x-ray here, in some cases, there will be this kind of Westermarck sign. So what is this Westermarck sign? This is basically going to show you that focal area of oligemia, which is the reduced blood flow in the lung fields that is distal to the emboli. And this is going to lead to a relatively darker area on the chest x-ray. Again, with a Westermarck sign, this will show you a hypolucent or a darker area on the chest x-ray. So this is basically what a Westermarck sign is. A much darker area being pointed. Okay. So again, reduced blood flow into this area. Okay. So that is the Westermarck sign. Now let's go further here with the other sign. The Hampton's hump. So what is this? This is now the dome-shaped pleural base opacification in the lungs that is caused by the PE and probably be attributed to the lung infarction, although it can result from other causes, maybe a vascular occlusion, maybe of the aspergillosis, the angioinvasive type of aspergillosis. Again, this x-ray can possibly capture that Hampton's hump. And so this is going to look just like this. Here we go. Where exactly the arrow is pointed at, it has that dome shape, pleural-based opacification. This kind of whitish area with that dome shape, this is the Hampton's hump. Again, this is going to signify the lung infarction, which is the result of that blockage of a larger area of the pulmonary arterioles or artery. Okay. So again, don't forget the Hamptons or the Westermarck sign. Now at this point, we're going to talk about the pulmonary, actually the ABG analysis. So what are you going to expect during the early and also the later stage of the PE, especially when dealing with the massive or the submassive type of PE? Well, during the early stage, you will be expecting some low PaCO2. And the reason for that, it's because the person during the early stage will end up with the hyperventilation. So they are wasting way too much of the CO2. They're exhaling way too much of the CO2. And this can lead into the respiratory alkalosis. Okay, we're talking about early stage. Don't get confused here, guys. Don't get confused because nothing is going to be set in stone here. All right. During the early stage, you will expect the respiratory alkalosis. There will be a reduced level of your PaCO2, the partial pressure of the carbon dioxide. And remember, guys, the normal range of the PaCO2, yeah, that's the 35 to 45 mmHg. All right. Now, when there is a resumption, if the hypoxemia progresses, now this is the time that you will see the respiratory acidosis. There will be now accumulation of the carbon dioxide. You will see now an elevation of the PaCO2 greater than 45 mmHg. And so this is also a result to the buildup of the lactic acid and also the retention of the CO2 combined. This can lead to the respiratory acidosis of your patient. Now, why? Before we go to that one, why there is lactic acidosis in the patient? Well, remember about the anaerobic metabolism. The cells would really need the oxygen in order to carry out its major function, to generate the ATP, right? But if in the absence or the lack of oxygen, the cells will try to generate ATP in the absence of oxygen. This is what we call as anaerobic metabolism. And this is going to lead into the lactic acidosis, right? That's simple. Now let's move about or talk about the D-dimer elevation. What is this D-dimer? You probably have heard this kind of testing discussed among the nurses when you were back as a student, when they're talking about a patient with a PE. So the D-dimer basically is a test that will be increased beyond the normal reference because of the clot formation, and there is a succeeding release of the fibrin breakdown products. Again, the D-dimer elevation is caused by the clot formation and a subsequent release of the fibrin breakdown products. And again, our reference range for the D-dimer is normally less than 0.4 micrograms per ml. But when you're going to have a patient that has the DVT, the deep vein thrombosis, this is going to be elevated, guys. All right. So when a patient has pulmonary embolism, this testing will also be ordered as part of detecting presence of any kind of clots or the DVT that has progressed into a P. All right. So that's simple. D-dimer elevation. Alrighty, now let's talk about the nursing care, which I very much like. What are you going to do back when you were assessing your patient that all of a sudden had that chest pain out of nowhere, that patient that has been 2 days post-op total knee replacement? So what are you going to do this time? I really want you to think as an RN and think really critically what you can do in order to allow the treatment process. It can really to allow you to streamline your nursing interventions as well. So I want you to do this time. So in that case, when the patient suffers the chest pain, could be that their blood pressure is somewhat kind of on the low side now, and the oxygen level is tanking from a 96% room air. Now it's probably 90%, hanging somewhere there in the 90 to 89% room air. I don't like that. It can probably progress into much lower level. And so what you're going to do here, you're going to administer the oxygen. Go right ahead, do that, and put the patient in high Fowler's position, and this will allow their maximum lung expansion. It's not going to really resolve, but somehow it can help, right? It will allow the maximum expansion of the lungs through allowing the diaphragm to go down further, and also to initiate IV access if there is no IV access. And if you are in the middle of that, let's say maybe the patient had IV access 2 days ago, and the patient is now complaining of some pain already. That IV access is no good. You have to get that out. So you really need to initiate IV access insertion, because you're going to expect possible anticoagulation here really soon. And once you probably call the medical provider, or let's say there is a sudden change in your patient's status, all of a sudden you're faced with all these weird assessment findings that we talked about on the previous slide. All those, if there is a massive emboli, yeah, you really have to expect those manifestations. And so what you might end up doing, you probably would have to end up calling the rapid response. Basically, this is going to be the group of personnel, could include the critical care nurse, the pharmacist, the laboratory technician, the phlebotomist, the nursing supervisor, and also the other ancillary services. They are going to be activated, and they're going to help out with this patient, because this is an immediate scenario that would really require immediate attention. Okay, we don't want to sit on this one, because those right-sided heart failure can occur really fast in this scenario if the patient has a massive peak. Now, if we probably had ended up with the doctor being notified by the after the patient has been assessed, then immediately anticipate about the following prescriptions. Possibly the medical provider has ordered initiation of the TPA, which is a thrombolytic agent. Okay, tissue plasminogen activator, which is going to lyse the clot. It will dissolve the clot. So this is going to be one of the mainstays in the treatment of a massive PE. Or the doctor might end up ordering the anticoagulation through IV, which is the unfractionated type of heparin, IV. We're talking about IV, not subcutaneous, right? This is going to be done in a protocol wherein you're going to have to follow into the different dosing schedules according to the levels of the patient's activated partial thromboplastin time. And so you're going to base the uh, adjustment of the dose according to what level the patient is at for the APTT or the PTTT. And so before we're going to initiate this, we'll make sure that you have obtained the patient's weight, because the medication, especially the heparin, is going to be weight-based. And so make sure that you have the most current weight of the patient, and because the pharmacy will need this in order to calculate the exact dose. All right, make sure you have that information. Now, as soon as you are going to receive that order, expect that there will be possibly a loading dose wherein you're going to have to uh, give the loading dose via the injection through the IV route. So it could be in a form of, yeah, I really can't give you the dose now because it can really vary according to the weight of the patient. But in my experience as a med-surg nurse in the past, I've given about like the 5,000 units as a loading dose injection IV. Um, yeah, but I had so many varieties of patients. So I had like an obese and also like the medium size. So I really cannot really remember the exact dosing for the rest of them. But again, you have to really be on your toes at this point when you're going to administer or start the infusion. Make sure that you are collaborating with the unit secretary, the laboratory department, that whenever there is a need for us to monitor the PTT, they have to really do it on real time. If it's going to be every 6 hours, they have to show up with every 6 hours in order for us to critically adjust the dose. Maybe the patient will be getting way too much of the medication, or maybe the dose need to be increased for this patient. So that's all about the initial treatment of the patient during the acute phase. Now, we're also going to monitor the lung function of the patient every 30 minutes. We are going to auscultate the patient's breath sounds, the rhythm, the rate, and also the pattern of their respirations, and also observe into the symmetry, how they're breathing, okay? Because if you're going to see some asymmetric movement of the chest, this is possibly going to be caused by the atelectasis, the lung collapse, and we really don't want that, okay? Now, part of the care here is to observe for the skin color, the capillary refill of the patient, make sure it's less than 2 seconds for this patient. Look for the discoloration, the cyanosis, look for the extremities if there's any cyanosis or mottling as a sign of a severe form of PE. Make sure you do that, guys. Now, we're also going to observe the position of the trachea. This is what I'm talking about. As a complication of the atelectasis, if there is a huge involvement of the clot and also the lung field, this can potentially cause shifting of one side of the lung to the other. It will push the normal lung to the other side, okay? So there is now going to be deviation of the trachea. Not good, not good. Now, we're also going to have to monitor the cardiac status of the patient, and we'll have to compare the blood pressure on both arms, as we know that there is going to be hypotension, both systolic and the diastolic, and check into the pulse quality, because we know that the patient now is probably having the low cardiac output, and you really need to pay attention to the amplitude of the pulses here, okay? Now, part of the care here is to make sure you place the patient into continuous cardiac monitor device. This is a must. This is a must because your patient can potentially go into cardiac dysrhythmias when they have a PE, all right? And also check into their jugular vein, especially the external jugular vein, because they can possibly manifest the positive JVD, and this is caused by the congestion of the blood coming from the right side of the heart. The backflow of the blood coming from the pulmonary circulation going into the right side of the heart, the right ventricle, and the blood will eventually go back up into the venous circulation. Of course, you're going to see that JVD. Now, Look also into the petechiae of the patient. Again, this is going to be caused by the rupture of the capillaries, caused by the increasing pressure in the venous circulation, or it could be a sign that the patient has developed that disseminated intravascular coagulation, or the DIC. Now, we're also going to monitor the patient's level of consciousness. This is a must because when your patient's level of LOS, the level of consciousness is deteriorating, that simply means that the brain is not getting enough blood supply, right? It's not getting enough oxygen. So if this is going to be prolonged, yeah, your patient's going to end up with some anoxia, right? We don't want that. We don't. And so you really have to be attentive in assessing your patient, make sure that you are delivering the administration of, deliver the oxygen. Um, Make sure that you really have to kind of do your step-by-step process in your assessment. Now, emotional support is very important here because of the increasing stress in the midst of the situation. Probably the family were around this time when you were assessing the patient, and all of a sudden, everyone is freaking out because their loved one is in a sudden change of mood with a PE going on. And so, emotional support can really do wonders here, especially when dealing with the patient's family and all of the patient themselves. Now we're going to talk about the pharmacologic management of our patient. And so I've mentioned about some medications earlier. And the mainstay here in the acute phase is the use of the unfractionated heparin, or I'll just include here the low molecular weight heparin, which is still being used in some practices. But if you're in the acute care setting, most often you're going to be seeing the unfractionated heparin being used because this is something that can be monitored because of the APTT or the PTT that can be drawn at least every 6 hours, or whatever is being ordered by the medical provider. This is going to be closely monitored. However, if we're going to get a treatment plan for, let's say, a low molecular weight heparin like the Lovenox or the enoxaparin, there's no lab testing for that one. There's none. Okay. And so it's not really easy for us to determine if the medication is on its therapeutic level because there is no blood draw that can evaluate the therapeutic effect of the Lovenox or the enoxaparin. Okay. But again, I said in some practice, maybe a clinic or so, when a patient has a milder form of the PE, then probably they're going to benefit the use of the low molecular weight heparin, and they're going to be instructed to use it at home because this is something that can happen to them as well. They are going to be to do self-administration of the low molecular weight heparin. But in our scenario or situation that I presented to you in acute care, we're going to expect the administration of the heparin and fractionated type. And again, weight-based. You have to keep monitoring the levels, the PTT, every 6 hours, and we're going to adjust the dosing. We're going to have to use the IV pump for this, guys. Don't forget, we're going to use the IV pump because we're going to deliver the medications in units. All right? Yeah, somewhat kind of a difficult and a little bit intimidating at first, but once you get to experience a lot of these patients, you're actually going to be a adrenaline junkie as well, right? And so we're going to talk about the nursing care here, especially when you're going to deal with this patient receiving the unfractionated heparin. Your role here is to assess the patient for the possible contraindication. That is your role as an RN. First things first, assess the patient for any allergies or if they have any possible contraindications, such as the following. If they have some active bleed going on, maybe they have an ongoing peptic ulcer disease, or they have a recent stroke or a recent trauma. You're not just going to read the chart about these medical history, you have to inform the medical provider. It is going to be helpful, especially during this phase, acute phase. Inform them, about these possible contraindications. Now, we're also going to monitor the coagulation studies. And this is going to be encompassing the unfractionated heparin, or it could be the warfarin. We don't have a test for the low molecular weight heparin. Please pay attention to that one. The enoxaparin, let me write that down here. Okay, please forgive me, guys. I am going to have my pad pretty soon, so you will see my handwriting much better in the next few days. Enoxaparin. So this is the low molecular weight heparin, LMWH. So this is that medication that is not going to be tested for therapeutic level. It doesn't. Only the heparin, we can test it by the PTT. And for the warfarin, this is the test that we are expecting. The prothrombin time, okay, PT. This is the test that you will be expecting to be ordered when the patient will now be given the order to take the warfarin therapy. Guys, I just want to emphasize here that the warfarin is not the medication to be ordered during the acute phase. Why? Because this is oral, it takes about good 2 to 3 days for this medication to start working. Again, the warfarin is not indicated during the acute phase of PE because it doesn't work up until the second or third day. It will not do anticoagulation during the acute phases. It will not work, okay? However, though, the warfarin will be started maybe the second or third day while the patient is still having the heparin infusion. And this is to allow bridging in order that there is now an allowed time for the warfarin to start working in order to cause anticoagulation on its own. And by the time when the PTT level is much more stable, while the patient is still receiving the heparin anticoagulation, when the doctor will see that, hey, we are achieving at least therapeutic levels of the heparin infusion, then possibly they're going to decide on discontinuing it during the fourth or fifth day once the heparin infusion has been started. And so that's the time that the heparin infusion will be discontinued, and then the warfarin will be continued all throughout. Okay, so the warfarin, again, is not used to anticoagulate during the acute phase. This is only to bridge the anticoagulation because of its low onset. All right, it takes good 2 to 3 days to work. All right, now here is our normal value for the PT, and I'm talking about 11 to 13.5 seconds, and this is the value when the patient is not on the warfarin. Okay, again, that value right here, 11 to 13.5 seconds, is the value for not getting the warfarin. Now, our next testing here that will be associated with the use of warfarin is the international normalized ratio, or known as the INR. And so this is the level when the person is not anticoagulated with the warfarin. Okay, look at that, 0.8 to 1.1. This is your baseline number. Like you and me right now, we're not getting any warfarin. So you are in that anticoagulated range. However, if the patient is in the warfarin therapy, the target range will be, let me get my eraser here. Now I'm missing my eraser. Hang a second here. Erase. All right. So when we are treating the patient with a warfarin, this is going to be our target range. It simply means that our patient's blood is now anticoagulated, it's being thinned. And so it will prevent the additional growth of the clot. So for example, if this is the blood vessel or the capillary or the arterial, and the clot is lodging here, when the patient is given any form of anticoagulant, let's say the heparin or could be the warfarin, the anticoagulant will prevent the increase in the size of the clot, okay, as we are thinning the blood. So the blood that is in the circulation is actually thinned. It's not as viscous as before. And so it will not add to the growth of the clot. And this is the goal in the anticoagulation therapy. We are preventing the growth of the clot, right? Now, talking about the next testing here, the partial thromboplastin time, which is normally 25 to 35 seconds. And this is the level when the patient is not getting heparin. No heparin. I'm just putting there's canceled 0, no heparin. This is the baseline information, 25 to 35 seconds. However, when we are treating the patient with the heparin infusion, this is going to be about 1.5 to 2.5 times the control value. And so the range usually be at 60 to 80 seconds. All right, so this is going to be our expected therapeutic range of the heparin infusion. I'm talking about the infusion, not the subcutaneous. No, that is quite different. The 5,000 unit subcutaneous heparin, that is for the DVT prophylaxis. What I'm talking about here is the IV heparin and fractionated heparin infusion. And so this is something that we need to obtain before we start the infusion. We're going to have to obtain baseline info about their partial thromboplastin time and also initial values of the INR and PT. All right, we have to get those baseline information, and so we can follow up and compare it later on once the patient is placed on these pharmacological therapy, right? Now, another testing that we are going to anticipate here is the complete blood count. So why? Well, because the platelets and the hemoglobin can be potentially influenced by the medication. Well, of course, if the patient will start bleeding. And of course, the heparin can cause thrombocytopenia. And if they're going to bleed out maybe from a puncture site, or it could be they're bleeding out because they have an ongoing hemorrhoids. Yeah, nah. And so if the bleeding can be kind of significant, it could probably cause a drop in the hemoglobin level and or also the red blood cell count, RBC. There will be significant anemia, and I really don't like this. I don't. And maybe there will be bleeding in the stool as well. Very hidden blood. We call it the hemocult. All right. So that's why we really need to monitor for the platelet counts, because there is a huge incidence of the heparin-induced thrombocytopenia, yeah, in the U.S. And that's why some of the medical providers have stopped using the heparin as a first line. So they're gonna order the what do you call this? The different kind of infusion, okay, not the heparin. Now we're going to talk about the observation about the different adverse reactions to the anticoagulation. There are many, guys. So our care doesn't just stop in the administration of the medication. No, it doesn't. That's why you got to get busy here, guys. This is a critical situation that you need to attend. And so there's a whole lot, such as the thrombocytopenia. There's also anemia and the hemorrhage. And so part of the care here, especially in the hospital that I work with, and in so many medical institutions or even the magnet hospitals, they have a specific order set once the medical provider decides on implementing the anticoagulation with the heparin. That order set will put everything there, the dose, the other nursing orders there, also other laboratory testing such as collection of stools, times 3 while the patient is on the anticoagulation in order for us to monitor, make sure that we are watching the patient for any possible GI bleed. And so we are going to collect the stools once a day, 3 times or times 3. And it could vary from another hospital to the next, but that is often the standard. All right. So I hope that I was able to kind of stimulate your brain here, just talking about the different mechanics of how we're going to treat this patient with the massive or the submassive type of PE. Now, another is the administration of the direct factor 10A, which is actually the activated factor 10A. And these are your rivaroxaban, the apixaban, and the fundaparinux. So these are oral medications. Again, these are not applicable during the acute phase. However, these are anticoagulants that will be more appropriate during the later part of the treatment, as if they're going to be sent home for maintenance of the anticoagulation. They're going to be using the rivaroxaban and the apixaban. However, this one right here, the fundaparinux, which is another anticoagulant that is given as a subcutaneous. And this is something that actually I learned when I worked into a different hospital, because I was working like a full time on the other one and a part time into another hospital. So they did a little bit different into their hospital. And so this is the first time that they've used the fundaparinux as the anticoagulant, which is in the subcutaneous form. And so this is a direct inhibitor, factor 10A inhibitor kind of medication. Now, what is really the nursing care here for the direct 10A inhibitor? Well, we are going to still assess the patients for signs of bleeding, of course, and also check for any possible hematomas. Could be epidural, or maybe some intracranial bleed, retinal bleed, which can possibly lead to some irreversible blindness and adrenal bleeding. Uh-oh, no, we don't want that. And possibly GI bleed as well. So these are the things that will be incorporated into your teaching when you are sending this patient home with these 2 oral anticoagulants. This is applicable in the acute care setting, the fundaparinux. Now, let's talk about, especially if in case, let's say, with the use of a epidural catheter. This is something that needs to be talked about because there's a need for us to delay the medication administration for at least 18 hours before and 16 hours after removing an epidural catheter because of its high risk to lead into epidural hematoma. All right. Now we're also going to have to observe the patient for any anticoagulation adverse reactions. You already know those. And so like thrombocytopenia, anemia, hemorrhage. Those are the main 3 things, the 3 sisters. And we also have the direct thrombin, dabigatran, direct thrombin inhibitor. Again, this is PO. Not appropriate during the acute phase, but will be possibly ordered for home use during the discharge to allow the patient to use this part of their anticoagulation. And so we're also going to monitor the patient for the bleeding, the signs and symptoms of blood loss. Again, back here, we're going to have to observe the adverse reactions such as thrombocytopenia, anemia, and hemorrhage. And we also talk about the thrombolytic therapy, which is the alteplase or the TPA, tissue plasminogen activator, TPA, which is the clot buster. It dissolves the clot. Right? That is a clot buster. So what are we going to do as part of the nursing care here? We're going to have to assess the patient for any possible contraindications. And here are those: bleeding disorders or maybe uncontrolled hypertension, because if the patient's blood pressure is high, we don't want the patient to bleed out if in case there is a rupture of the arteries, right? We don't. There's also going to be a possibility of active bleeding. We don't want this. So that will really contraindicate the patient. And also the peptic ulcer disease, any history of stroke or recent trauma, maybe surgical procedure, pregnancy. Those are the things that will potentially contraindicate the patient to using this. And we need to monitor the patient for the bleeding, also monitoring their vital signs frequently at regular intervals per protocol. Guys, please take note that when you are going to be the nurse assigned to deliver the TPA, usually this is only done by the critical care nurse. Yeah, it's not going to be done by a regular med-surg nurse. This will require for the critical care nurse to do the infusion because this is gonna ask them, or this is going to require them to do a whole lot of monitoring, frequent monitoring of the vital signs. We're not talking about just the vitals, cardiac monitoring. We have to talk about frequent checking of their level of mentation for any signs of bleeding anywhere in the body. Could be that there is a slight change in the pupil size that could possibly indicate some bleed in the brain, dilation of the pupils. Yeah, these are the things that you need to keep an eye on. Petechiae, bleeding into the IV axis site or any of the venipuncture site. Those sites could potentially bleed out. And so again, this will require one-to-one nursing care. Okay. And so back in my experience here, usually for those patients that have received the TPA, they're going to be admitted into the critical care for at least 24 hours or so. And if there's a need for them to stay there quite longer, then they have to. But most of the time before they're going to be transferred to the med-surg unit, make sure that they are stable in the ICU. They're going to be monitored there. If there's any other complications, then if they're going to be appropriate to be transferred to the med-surg or let's say the progressive care unit, then that would be the next step. But then again, once you receive the patient, the frequency of the vital signs monitoring will be frequent as well. So in a shift of, let's say, 8 hours or let's say a 12-hour shift, instead of doing the assessment every 4, usually what you're going to do here is that you'll be assessing your patient every 2 hours. The vital signs will be about like that as well, every 2 hours. With a standard med-surg kind of care during the transfer or right after the transfer of the patient. And this will now be changed into a regular or routine schedule as far as like the checking of the vital signs and assessment. It will be less frequent when the patient is more stable during the second or third day. All right. So I hope that you're able to understand really how we transition in the delivery of the care of the patient from the acute into the later stage of the PE. Now, part of the care here, especially in the surgical management here, is to prepare the patient for the embolectomy. If there is a huge clot that is significantly obstructing the main artery in the lungs, well, there's a need to remove that clot immediately through that procedure. So the embolectomy, let me see. Yeah, this is going to involve with the insertion of the catheter in order to remove that clot. Okay, but before we send the patient to that procedure room, we're going to have to get their consent, make sure that they have been NPO. And once they get back to your unit, we're going to have to do a whole lot of vital signs monitoring and also their intake and output, watch for any complications. We have to look into their wounds to see if there's any bleeding or signs of infection and also deal with their pain. Okay, so those are the things that we need to anticipate for the embolectomy. Now, if your patient is a candidate for the placement of the vena cava filter, okay, or the what we call as the IVC. This has always been referred to as the IVC filter, which is the inferior vena cava filter. This is going to be placed somewhere here. Of course, inferior vena cava, right? So let's expand that one. This is basically like a strainer. So it will capture any remainders of the clot. in order to prevent it from traveling into the heart. So the filter is something that can be implanted somewhere here. Of course, there are some complications involved, but this is one of the other treatments that have been known to be effective as well, especially for those that have recurrence of the PE. If they have really at risk to developing a lot of the DVTs and pulmonary embolisms, they're going to require the placement of the vena cava filter. And of course, it will um, require removal if there is no significant amount of clots that's kind of lodged into the filter itself. Of course, it has to be removed, right? And will be replaced with another one. Now, how are we going to prepare this patient? Well, pretty much the same. We are going to get the consent of the patient. We have to keep them NPO, and we're going to monitor the days after the procedure. No, nothing of that. All right? Make sure that your patient understands this teaching. Make sure that they're given some notes or any patient education pamphlet that contain this information, or maybe their family members need to be taught as well in order that they can warn or caution their family member, possibly they're forgetting, right? So yeah, help the family to understand the treatment as well. Now we're going to talk about the patient education here. As if our patient is getting better and they're ready for discharge. However, they still need to continue the treatment at home with the anticoagulation. And so with a patient that is homebound, we definitely need to set up the home care services in order to perform the blood draw, okay? So this is the case when there is the use of warfarin. If the medical provider decided, let's say the patient and the medical provider both agreed that the patient will be taking the warfarin at home for continued anticoagulation, then this will require the weekly blood draw, okay? However, if the patient is using a different kind of anticoagulation like your NOACs, or we call them as novel oral anticoagulants, NOAC. So these are your apixaban, Eliquis, and Plavix. Okay, so those are the NOACs, novel oral anticoagulants. So these are not going to be tested using a blood draw. No, we don't know their therapeutic levels. There's no testing yet that is established to check for their therapeutics. So that is why the warfarin is still common. Yeah, I think so. Although some of the medical practitioners now are kind of leaning towards the NOAC, but again, it's kind of hard really to tell if the medication is stable in their system because we don't know. There's no testing, and so that's the downside of it. Now, for the warfarin, again, the weekly blood draws is going to be implemented, or else the patient can bleed out if, let's say, the body probably is thinning the blood way too much. And so this would really require adjustment of the dosing as well, because the first 4 weeks of the Coumadin therapy is the most critical, because this is the time when the blood levels of the Coumadin is going to be established yet. Okay, and so you will expect that there are probably some changes in the dose of the medication, because usually what they're gonna order here is to give daily dose of Coumadin to this patient. So most often they're gonna start with a particular number, but again, it can vary. Now, talking about oxygen setup services, this is also going to be important, because for those patients that may had the massive form of embolism, of course, they're going to suffer the residual collapse of a portion of a lung, right, atelectasis. And so they definitely need some supplementation at home. So setting up with the services, with, of course, the case manager will be involved here. But you're not gonna just throw this to the case manager, guys. You are the primary nurse involved in the care. So you have to be proactive. Make sure that you point this out to the case manager. Hey, this patient is brand new, no history of PE, never used oxygen at home, so they don't have any setup. So you have to inform the case manager around this time, hey, our patient needs this one before they need to be sent home. Make sure that they have this portable oxygen device. And so they know what community service is available for them just in case they will need some support. Make sure that you communicate with the case manager as well. Now, there are some recommendations that you're going to need to prevent the recurrence of, I forgot to put here, recommendation for the prevention of recurrence of the PE. So part of that will be the smoking cessation. As we have talked earlier in the mechanics of the coagulation, the HES, remember about the hypercoagulability, the endothelial injury, the S, the stasis or the venous stasis, remember, smoking is actually part of those. And so smoking cessation is very important, guys. And also avoiding extended immobility is a must. All right. Also encouraging the patient to do physical activity and the application of a compression stockings, because these stockings will actually promote the circulation. Now, also teach the patient to avoid crossing fingers, I'm sorry, to avoid crossing their legs. Yes, avoid crossing their legs. Just put it right there. Avoid crossing their legs. And because this is going to impede the blood circulation. Now, if the patient is taking the warfarin therapy, now this is very important. Very important. So I really want you to pay attention here, because way back during my time in the early 2000s when I was a brand new RN, in our textbook, med-surg textbook, our reviewers way back then, the guideline is to decrease the intake of vitamin K when the patient takes the Coumadin or warfarin. But that is no longer the case this time. According to the evidence based in the recent studies, it is much safer that the patient will be on the same amount of vitamin K foods that they have been used to ingesting for quite some time, rather than having to change their diet. Okay, so that is a whole lot safer compared to the decreasing intake of vitamin K rich foods. That's no longer applicable. Again, we are no longer gonna teach the patient to decrease the vitamin K intake in this patient. All right. The new guideline now is to do not increase and to not decrease the amount of vitamin K rich foods, because of course the patient will be tested in their INR, the PT, in a weekly basis. We don't want to disrupt the anticoagulation by decreasing or increasing their vitamin K. No, we don't. Now, we're also going to be encouraging the patient to be compliant in monitoring their PT-INR. So let's say, for example, if there is already a pre-arranged weekly visit, so somebody from the clinic is going to visit the patient in their homes or maybe the assisted living or the nursing home, then that's good, right? That would really be better for them to have their blood tested regularly, right? But for those patients that are supposed to be able to go to the clinic or the lab for their blood draws to be taken, they need to really comply regarding the schedule. Make sure that they are told to go to the clinic every Thursday morning, then they better go to that clinic every Thursday morning. Do not delay their appointment, because the range, the therapeutic range of the warfarin will really matter just within a day's time. And so make sure that the patient will adhere to that schedule, okay? Now, we're also going to monitor for and avoid bleeding, and this is part of our care here, guys. So this is probably going to come out in your exam for those patients that have bleeding tendencies. So we're going to teach them to avoid aspirin-containing products, also to check for their gums and mouth daily, and to have them use the soft bristle toothbrush in order to prevent the bleeding, and also to avoid the use of the dental floss. Yes, I forgot to put that there. Dental floss and toothpick. No use of the dental floss and the thick. NCLEX probably would get so tired using um, the toothbrush scenario. So probably they're going to trick you on a scenario with the use of a dental floss or toothpick. Yeah, it's been kind of repetitive already for so many years, more than 20 years already. So yeah, they might change their way of testing, presenting your data. Now, the use of electronic shavers is actually would be beneficial for those male patients instead of having them use the straight razor. So make sure that this is available and they are taught to do this, especially if they are really proactive in doing their self-care. So if they're going to be sent home with the anticoagulation, no matter what, if there is going to be NOAC or let's say warfarin, they have to use the electric shavers instead, not allow them to use the straight razors anymore. Now, part of the care here is to educate them to not blow their nose because this can potentially cause bleeding. And we're also going to encourage them to maintain their hydration, not overdo it and not to underdo it. Make sure that they are just sufficient. And they also do their range of motion exercises to allow proper circulation, prevent any sluggishness, and that's it. And so I hope that you're able to learn much from this um, session. And we will be doing some Q&A later on in the next few days to follow up your learning with a pulmonary embolism. So if you do have any questions regarding the subject or regarding the topic, I really want you to message us or send or type in your messages or comments below in this video so we can address them if you are kind of like, I'm not sure if I quite understood that lecture. So I really want you to do that so I can reinforce you in the next lecture. Okay. So I really thank you for your attendance and I hope that you enjoyed this and make sure that you hit the like and subscribe button and also the notification bell so that you can help us out in disseminating our free classes that we do daily. And again, with a new schedule, we will be doing this at 9 p.m. every day. Let me go back into that slide. Hang on a second. Reminding everyone that we are changing the schedule starting on June 6th or June 5th rather. We will be changing the schedule to 9 p.m. Eastern Standard Time. All right. So again, our next class will be on June 5th, 9 p.m. Well, thank you so much and I hope you have a great day and